So my name's Koosh Desai. I'm a general internist by training. I'm also the lead person on the CRC screening echo and one of the medical directors along with Dr. Hotz for the Georgia's colorectal cancer control program. The goal of that program is to increase colon cancer screening throughout Georgia through evidence-based interventions. One of those interventions is provider education and feedback, and we're utilizing the echo model for that intervention. We provide, so the echo model is based on learning from content experts and from each other with the goal of getting patients screened for colon cancer. We want these sessions to be interactive, and we have plenty of opportunities for questions. So be thinking of questions that you can ask our experts as we're going through the didactic sessions. First, let's go over today's agenda. Samia, you can go ahead and start doing the agenda. There you go. So first we'll have introductions. Then we'll have a didactic presentation from our content expert, Dr. Itzkowitz. Then we're going to have a case presentation by Cynthia George and Robby Amin. And then we'll end with wrap up and announcements. We also have Claudia Gillian and Sadia Ali, who are echo coordinators, and Samia Ibrahim, who is managing the controls. Now I'll introduce Dr. Doug Patton. He's going to be today's facilitator. Dr. Patton is the campus dean for Medical College of Georgia Southwest Campus, and he spent most of his career as a rural general surgeon. Doug?
Thank you, Koosh. It's my pleasure to be here on this first session of what we hope will be a series of very productive sessions to help address the colorectal cancer screening rates here in Georgia. I just want to give a special word of acknowledgement to Dr. Hotz, who's one of the participants here today, but we are here with our first series of Project Echoes primarily because of his persistence and his drive and his understanding of the value of this platform for sharing information. So Dr. Hotz, thank you for keeping me on track until we finally got here. It's a big day for us both. So thanks for that. But as we start, I want to do just a few little housekeeping things that we'll cover in this first session. Project ECHO, that ECHO stands for Extension for Community Health Outcomes. One of their favorite expressions is moving knowledge instead of people. In other words, we want to improve the care that you folks can deliver by helping you with your own competence and confidence in providing care for these folks and making sure that you're able to share with each other the best tools to make that happen. Next slide, please. So ECHO is a collaborative education model. It's meant to be bidirectional, actually multi-directional, not didactic in complete. We rely heavily on this notion of learning loops. In other words, the specialists with the content expertise, people will provide a short didactic, but we also want to engage all the frontline clinicians who are engaged in the Project ECHO to share information with us, to ask questions, things like that. You sharing your experience with these challenges is how we all learn. This was developed at the University of New Mexico Health Sciences Center, and as a reminder, we're not providing care to patients. This is an educational platform. If you have more questions about ECHO, you can go to their website at echo.unm.edu. Next slide, please. So it's a replication model, and this is achieved through the creation of a hub and spoke model for the TeleECHO sessions. In this case, the hub is based at the Georgia Cancer Center at Augusta University, along with the Georgia Colorectal Cancer Control Program. The partners of the GCCP, as Dr. Hotz likes to refer to it, are the Georgia Center for Oncology Research and Education, that's Georgia Core, Augusta University, and importantly, Horizons Community Solutions, one of our key partners, and you'll be hearing more from them later on today. The spokes, which is where the magic happens, that's you. It's the clinics all around the state who are providing the care, that you're on the interface where the action happens with the patients, and we want to help make sure that you're able to do the best job possible. Next slide, please. So we'll be covering a number of topics across the screening sessions. Of course, we'll be updating you as we go in advance of our monthly sessions together, but we'll talk about best practices. We'll address health equity issues, reducing healthcare mistrust, utilizing evidence-based interventions, and also helping us all to get used to using the information that we gather during these projects to tell the best possible story. It's sometimes through the power of a story that we're able to change behaviors. And this is the inspirational message that we want to reignite colorectal cancer screening efforts, especially coming off a 2-year lull in the action that was forced on us by the pandemic. Next slide, please. So as a participant, you will be asked to present and discuss your challenging cases, but most importantly, the lessons you learned from them, either successes or failures. We can learn from all of that. We also hope to enhance your ability to extend what is currently specialty care someplace else, but to extend that back to you and at your home site where you can deliver that straight to your patients. Next slide, please. So for education and quality improvement purposes, all these sessions are recorded, as you heard earlier, and participation implies consent. Just so you know that we're maintaining patient privacy here. We're not using these sessions to share any PHI or to create consultations on specific patients. So when it's your turn to share in the future, we'll ask you not to mention PHI or to share any images that contain PHI. You can email us at that email address if you have questions about that. Also, the chat is always open. Next slide. So we do collect data. Project ECHO worldwide collects all sorts of data on registration, participation, question and answers, poll responses. Just about anything that we do is gathered so that worldwide this information can be used to improve TeleECHO programming, which also then extends into better care for patients closer to home. Next slide. As a reminder, although we've all sort of gotten used to using Zoom or Microsoft Teams, mute when you're not talking, remember to unmute when you do speak. For the purposes of this session, we'll ask that you rely on the chat to ask your questions or make comments. We'll be monitoring that chat and tracking comments and questions. If you feel like there's something that needs immediate clarification or something, please raise your electronic hand, which is you access that by hitting the reactions button on the bottom bar of the Zoom screen. You'll have a choice then to hit the raise hand icon. When you're recognized, we'll ask you to please introduce yourself after you unmute and share your comment or question. If possible, please leave your camera on at all times. We like to see all the faces across the screen. It's a lot better than a bunch of blank screens with names. If you are like so many people in rural Georgia, though, and you have broadband challenges, we'll understand if you have to mute your camera for the purposes of not overrunning your broadband capacity. We suggest using gallery view so you can see all the participants who are participating. And again, you can direct your technical questions via the chat to either Claudia, Saida. Saida's email is sayali@augusta.edu. Next slide. So for those of you who were able to join us a few minutes early, this is the QR code for the screening questionnaire. We'll give you a couple of minutes to do that, but that link is also in the chat if you want to just move your cursor over and click on that and do it in a different field. We'll just pause for a minute or two here. These are some pretty quick questions. We tried to make them all multiple choice, so it was easy to just click, don't overanalyze it. But take a couple minutes, if you will, to complete or start the survey. We'll be back with you in just a second. And we'll also be monitoring the chat if you're having issues.
Please follow the link in the chat. How do I get there?
Just click that link in the chat. You click the chat button on the bottom, the chat will pop up and it says, please click here to answer the survey.
It's under more, so it's more and then chat. And the survey link should be right there on the bottom of the screen.
And you may have to hover over the bottom of your screen for that toolbar to pop up and become visible. Did you find it? So we'll pause for about another minute and then we'll reboot. Again, don't overthink it. Nobody gets a grade here. While we're finishing up, I also want to introduce someone who just joined the meeting a few minutes ago, and it's Dr. Cortez, who is the director of the Georgia Cancer Center. Dr. Cortez has facilitated this whole development of not only the colorectal cancer screening program that we're all participating in, but particularly created a home for Project ECHO by allowing staff who work there to spend plenty of time. Dr. Cortez, we're glad to have you joining us today.
Thank you very much and welcome everybody. Glad to have you here. I hope you'll find these very informative.
All right. Hopefully that's giving everybody enough time to kind of get through or at least get started and well along the way in the survey. I don't want to take any time away from our featured speaker today. So it's my pleasure to introduce Dr. Stephen Itzkowitz, who is a professor of medicine and oncological sciences and director of the GI fellowship program at the Icahn School of Medicine at Mount Sinai. That's in New York for those of us who've not been that far north. His talk today is about colorectal cancer pathogenesis and screening guidelines. Dr. Itzkowitz is chair of the National Colorectal Cancer Roundtable, the first in the nation to demonstrate the effectiveness of patient navigation to enhance screening adherence. It'll be about a 20-minute presentation, and then we hope to have at least 10 minutes or so on the back end to give Dr. Itzkowitz a chance to respond to your questions and comments. So with that, thank you for joining us today, Dr. Itzkowitz, and we welcome you to the program.
Thank you so much, Dr. Patton and Dr. Cortez. Thank you. This looks like a fascinating program. I'm really honored to have been invited to this. Can you hear me? Yeah.
Yes,
I'm also impressed by how many people on the call have their cameras on. I teach in the medical school, and in the second year class, there's 140 students, and 5 of them turn their cameras on. So it's a pleasure to see some faces. And let me also acknowledge that we are in the presence of royalty. Dr. Hotz, in my opinion, is a king. He almost single-handedly has moved the needle nationally on colorectal cancer screening rates. He's an amazing innovator with an incredible amount of energy and enthusiasm and initiative. And he was the one who coined the national movement 80 by 18, 80% screening by 2018. Now, as you know, our motto is 80% in every community. And I see that there's a lot of communities represented on this call. So Jim, thank you for everything that you've done. I was asked to give an overview of colorectal cancer. This is really going to sort of set the stage, I think, for understanding the disease a little bit better and why we should be screening and how we should be screening. So you're probably aware that colorectal cancer is a disease of so-called westernized parts of the world. So North America, Western Europe, Australia, New Zealand. You don't see very high colorectal cancer rates in Asia, Africa, South America, even Central America. And while that is encouraging that there are parts of the world where we don't see a lot of colorectal cancer, we can't be misled, because when people migrate to the United States from parts of the world that are low in colorectal cancer, within a generation, their rates of colorectal cancer actually start to come up to that of the surrounding population. So we really have to view everyone in the United States as being at risk for developing colorectal cancer. Can I have the next slide? And although this is a couple of years old, the numbers haven't really changed. Colon cancer is the 3rd most common cause of cancer deaths in men and women. And if you just include cancers that primarily affect both genders, colorectal cancer is second. So a very common problem, which is extremely unfortunate because it's been argued that colorectal cancer is maybe the most preventable cancer that we deal with. Next slide. So this slide shows you the, can you see my pointer? I don't know if that's, oh, maybe because we're not sharing the screen. Anyway, that's okay. I'll just describe it. So what you see here is in the middle bar is the white population. On the left is the incidence rates, and on the right is the mortality rates. And you see whites in the middle. And rates, both incidence rates and death rates, are higher amongst Blacks and indigenous populations compared to whites. And as I was mentioning earlier, rates amongst Hispanics and Asians are lower than that of whites. A lot of that is because those segments of the population tend to be relatively recent immigrants from low-risk countries. But as I said, as they stay in this country and have children who grow up in this country, the rates usually come up to that of the white population. But I'm sure you're all aware of the disparities related to the Black population and American Indian, Alaskan Natives. Next slide. So how do colon cancers develop? Well, fortunately, there is a very well-defined and a very identifiable precancerous phase, and that is the polyp. And we think it takes about 5 or 10 years for a polyp to develop and grow and develop into cancer. And what happens with a polyp is that if it's not removed, it will grow larger, and then a focus of cancer will arise in the top of the polyp and invade into the neck of the polyp, the stalk of the polyp, and eventually into the wall of the colon. So because there's such a well-defined and actually easily identifiable precancerous phase, that's what makes colon cancer so preventable. Is if you find it in the polyp stage and remove the polyp, you have prevented that cancer. And also because it takes so long, if somebody procrastinates even by a year or two, very often we still can get in there when things are very treatable and preventable. Next slide. So we used to think that all colon cancers arose from the type of polyp called an adenoma or an adenomatous polyp. But about 15 or 18 years ago, pathologists drew our attention to a second kind of polyp called a sessile serrated polyp. And this explains about 15 or even 20% of colon cancers. And we were missing these lesions for decades. In fact, if you look at the old colonoscopy literature from about 10 years ago, the data suggested that colonoscopy was very good at protecting and preventing cancers in the left colon, but not in the right colon. And that's because a lot of times these sessile serrated polyps arise in the right colon. And you can see in panel A very subtle lesion that has a little bit of yellow mucus on it. And for years, we thought, oh, that's just some mucus, and we would wash it off and keep going. But if you wash off the mucus and look carefully, you can see that there's a subtle pale lesion. And if you inject a little bit of saline with methylene blue, you can easily see this polyp now and shave it off. And so knowing that there's a second type of polyp that can give rise to colorectal cancer has really helped us in our prevention efforts. Next slide. So with adenomas, and even with sessile serrated polyps, polyps have to grow bigger before they turn into cancer. By bigger, we mean like greater than a centimeter. The polyp on the left is probably about 5 millimeters. That's not going to have cancer, and it takes a long time for that to turn into cancer. But as you can see, going from left to right, polyps get larger, and then there's a greater likelihood that cancer will arise in that polyp. Next slide. Now, if we have not been lucky enough to catch the polyp and remove it, and the person develops cancer, there's still good news in this whole story, because if we catch colon cancers at stage 1 or stage 2, with only surgery and nothing else, no chemotherapy, no radiation, no immunotherapy, just with surgery, meaning physically removing the cancer, there's better than an 85% 5-year survival rate for stage 1 and stage 2. And this slide shows how we stage colorectal cancer. So it always starts in the inner lining, the mucosa. And if it's only into the surface, the very top of the surface, but not into the muscle wall. That's stage 1. If it gets into the muscle wall of the colon, that's stage 2, as long as it doesn't involve the lymph nodes. Once there's lymph node involvement, the tumor itself can either go into the muscle or through the entire wall of the colon. But the key here is that stage 3 has positive lymph nodes, and stage 4 has cancer that has spread to other parts of the body. And you can see that once we're at stage 4, the 5-year survival is much, much lower. Even with stage 3 disease, those patients will get surgery plus chemotherapy to sort of make sure that their cells haven't escaped elsewhere. But even with chemotherapy, 2/3 of people will be alive 5 years later. So it's really important that people come in for screening, because even if we don't find polyps, even if we find colon cancer at an early stage, it's still a win in the vast majority of the time. Next slide. So if we haven't caught cancer early enough, this is one of the things that can happen. You know, colon cancers tend to scar and contract and narrow the lumen, and they also ulcerate. So you can see from the surgical specimen what kind of symptoms somebody might have. They might have bleeding, they might have some pain, they might have thinner bowel movements or difficulty passing stool. You know, many people get constipation, but most people who have constipation have that as a relatively steady bowel pattern. If somebody has new onset of constipation, you have to really begin to worry, especially if there's anything like blood in the stool. Next slide. And for those of you who may not be aware, the contents of your intestinal tract are liquid at the end of the small intestine. So whatever's coming down from the small intestine into the colon, into the large intestine, starts off as liquid. And so the stool that forms on the right side of the colon eventually forms as it gets to the left side of the colon. Now, if you have a cancer that's in the right side of the colon, it might bleed, but the blood will get mixed in with the stool, and by this time the stool firms up and passes out of the body, the patient may not see the blood. So there's usually occult bleeding for right-sided cancers. They may just present with iron deficiency anemia or shortness of breath or weakness. On the other hand, in the left colon, if a cancer occurs, there's not that much time, not that much room below or downstream for that blood to get mixed in with the stool. So the blood will come out as bright red blood. Also, because of the firmer stool on the left colon, if there's a narrowing, the patient will have obstructive symptoms or pain or tenesmus or rectal pressure. So that, to some extent, gives you a little bit of a handle as to where the lesion might be. But you still have to do a colonoscopy to be sure. Next slide. So the most common symptom of colon cancer that I tell people is no symptoms, no symptoms, and no symptoms. Those are the 3 most common symptoms. No symptoms at all. Because a lot of patients say, well, I couldn't possibly have colon cancer, I feel fine. And I tell them, nope. You could still have colon cancer and have absolutely no symptoms. If people do have symptoms, again, it might be a change in the nature of their stool, abdominal discomfort, unexplained weight loss, loss of appetite, or anemia. Next slide. So this slide summarizes the risk factors. On the left are factors that increase risk of colon cancer, and on the right are factors that decrease risk. So the strongest risk factors that promote colon cancer are age over 50, even age over 45 now, country of birth, like we've been talking about. There are some hereditary colon cancer syndromes like familial adenomatous polyposis and Lynch syndrome, which I won't be discussing unless you have some questions. And inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Those are the highest risk factors for colon cancer. But there are moderate risk factors with relative risk between 2 and 4. If you look at studies that have looked at populations that eat a lot of red meat or have had a previous adenoma or colon cancer, or even pelvic irradiation. In women, cervical and endometrial cancer with pelvic irradiation. In men, prostate cancer radiation. And modestly increasing risk would be high-fat diets, obesity, smoking, alcohol. And interestingly enough, a past history of cholecystectomy has been shown in many studies to increase colon cancer risk a little bit. We don't tend to include that in our risk stratification or worry too much about it, but it's an interesting phenomenon nobody understands. Maybe it's a change in bile acids. But patients say, you know, I can't change what country I was born in or come from. I can't slow down my advancing age. What can I do to lower my risk of colon cancer? The three most protective things are physical activity, the chronic use of aspirin or nonsteroidals, but really colonoscopy. Colonoscopy is the main thing that really can protect against colorectal cancer. By physical activity, even just walking, anything other than a sedentary lifestyle has been shown to be beneficial over a very sedentary lifestyle. Aspirin and nonsteroidals is a little bit controversial because of GI bleeding or other factors. But for people who are able to take long-term aspirin or nonsteroidals for other reasons, they seem to have a lower risk of colorectal cancer, but you still can't rely on that. You still have to have people coming in for colonoscopy. And then I usually tell patients to follow a high fiber, high fruits and vegetables, increase their calcium intake, folic acid. All of those things have been shown on a population basis to lower risk of colon cancer. We can't be sure for an individual patient that if they follow a high fiber, high fruits and vegetable diet, that they will lower their risk individually of colon cancer. These data come from population studies, but nonetheless, it seems to make a lot of sense. And interestingly, women who take hormone replacement therapy postmenopausally also have lower risks of colon cancer. But again, the risk-benefit ratio has to be weighed in terms of breast cancer and thromboembolism. Next slide. We don't usually put a woman on HRT only to prevent colon cancer. So who gets colon cancer? Next slide. If you look at the pie chart of all colon cancers every year, 2/3 or 70% are what we call sporadic, meaning there's no apparent risk factor. There's no family history. There's no genetic component. There's no inflammatory bowel disease. So 2/3 of cases just seem to come out of the blue. About 1/4 of cases will have some degree of a family history. So it's really important to take a family history for colon cancer. And then about 3% or 4% will arise in some of these hereditary syndromes. Next slide. So the various screening tests I'm sure you're all familiar with. The endoscopy tests are colonoscopes and sigmoidoscopes. We don't tend to use sigmoidoscopes very much in this country. It's used a lot more often in Europe. Next slide. Sigmoidoscopes are just shorter colonoscopes. These are the three most common stool-based tests. There's the fecal occult blood test, or the old guaiac cards, still used today. Fecal immunochemical tests, or FIT tests. This detects human hemoglobin in the stool and therefore blood in the stool. And then you're probably familiar with the multi-target stool DNA test or the FIT DNA test. And the kit is shown here at the bottom. So the multi-target stool DNA test will detect occult blood, just like the FIT test, but in addition, it detects abnormal DNA in the stool. And now if we go to the next slide, you can see why that test might be useful, is because there's not a lot of shed DNA or shed cells in a normal colon. The DNA gets degraded and the cells get degraded. But if you look above a colon cancer or even a polyp, the hallmark of cancer is that cells don't die and they just get sloughed off into the stool. So you can actually, with PCR and sensitive techniques, you can pick up microscopic amounts of abnormal DNA, even from a small cancer, even from a small polyp. So that's why adding DNA analysis really can enhance the detection of certainly cancers and in many cases, large polyps. Next slide. There's another test that's like a colonoscopy called CT colonography. It's been referred to as virtual colonoscopy. This is a CT this is done by radiologists. Patients clean themselves out. They go to the radiology suite. A catheter is put into the rectum. Air is inflated so that things can be seen. And then images are taken. And you can get very, very good images in qualified centers that do this. And you can see at the bottom right, all the way on the right is a regular sort of visual colonoscopy or optical colonoscopy. And right next to it is the same polyp seen on a virtual. Barack Obama had a virtual colonoscopy for his screening. Next slide. So this slide summarizes, I'm sorry if the bottom left didn't, I don't know, something happened there with the slide. This slide summarizes the screening test performance of the various screening tests. So of course, colonoscopy, the invasive tests or the structural exams are going to pick up cancers and adenomas better, as you might expect, because they're visual exams with very good specificity. With non-invasive tests, the multi-target stool DNA picked up in one pivotal study 92% of colon cancers, and 71, that should be a 71% pickup with FIT testing. And Hemoccult, the FOBT is in the 60% range or so. So these tests, these stool tests are very good at picking up colorectal cancer. They're not as good at picking up polyps. The multi-target stool DNA does better than FIT, but you can see that still we probably miss about half of polyps when we do stool testing. Now, the thing about FIT testing versus multi-target stool DNA is the specificity. So FIT testing has a 95% specificity, which means only about 5% of individuals who will have a positive FIT test will be false positive, meaning they'll have a positive FIT, they'll go for colonoscopy, the colonoscopy is normal. That's a 5% false positive rate. The multi-target stool DNA has a 13% false positive rate, so a bit higher. And that's often related to age. The older the patient is, like in their 70s or 80s, the higher the false positive rate. And now that we're screening people at age 45, the false positivity rate is actually only 5%, very, very similar to that of FIT. Next slide. So this is the menu of options that people can do for screening. This is the USPSTF guidance that came out last year, which is now in sync with the American Cancer Society that made this recommendation in 2018. And all of the societies now have embraced this approach where from 50 to 75 years old, there's grade A evidence that you should be doing one of these tests. The 45 to 49 age was announced last year as grade B evidence only because we haven't had as many studies, but still grade B is covered by most carriers. Between ages of 76 and 85, you should be individualizing. There are some very healthy people in that age group that would benefit from a test that could protect them for another 10 years. And then above 85, it's usually recommended that individuals stop screening. And you can see the tests here and the intervals that are recommended. Next slide. So we're going to finish up in the last couple of minutes with an emphasis on why did we lower the rate to 45. And what you can see in this slide is for many, many years, we started to see rates among 50 to 64 and 65 and older. The rates amongst men and women were going down very, very nicely and continue to go down. But at the same time, going back even into the 1990s or so, the incidence rates for people under age 50 have been going up. Now, clearly the y-axis is very different. The absolute number of cancers in young people is a lot smaller than in the older population, but that slope of the curve is worrying everybody. And to this day, about 11 or 12% of all colon cancers occur in people younger than 50. So this is a sizable proportion of the population, and it's really the only segment in the population where rates are going up. So we really are paying attention now to the 45 and older group. Next slide. A shout out to some of the work that we've done here in New York City, only to show you that if in a small town like New York, if every hospital in New York City could sort of up its game and try to increase its screening efforts, you can really increase screening rates and even eliminate racial and ethnic disparities. So this is data from the C5 Coalition in New York, where in 2003, we had tremendous disparities in colon cancer, in colonoscopy rates, and nobody was getting screened more than about 45 or 45%. We tried to get to 60% by 2008, and we actually outdid ourselves. We got to 60% by 2006, 2007. And this was just basically done by every hospital upping its game, trying to develop systems to get people in for colonoscopy with navigation, with reminders, with improving their electronic records, their referrals, their direct access. It wasn't a one size fits all. It was all done locally but without even a whole lot of effort. I mean, it was a lot of effort, but it was the kind of thing that people wanted to do anyway. And you can see that, the rates have gone up, and we're now at around 70, in the low 70% range across the city. So I think that's the last slide. Yeah, so I'm going to stop there. Hope I didn't take too long, and happy to answer questions. I know we have some case discussions before that.
Dr. Itzkowitz, that was terrific. Thank you so much for that. Encourage folks to either type something into the chat, or if you have comments or questions. I know Dr. Hotz's mind is just spinning away down there. He's got something to contribute, but raise your hand and we'll acknowledge you as we see you. I have one that I'll go ahead and start, and while others are thinking, Dr. Itzkowitz, we think a lot about colonoscopy sort of being the gold standard, and it appears to be the most effective even at picking up the earliest possible lesions in good hands. Many of these providers deal with populations that, even though they might actually engage the patient agrees with the notion of doing it, they may have trouble getting them actually to the endoscopy suite. Part of what we'll hear about earlier is navigation, but a lot of these things are payer barriers. How do you help someone who's in one of these rural provider sites who has a patient that can't afford to go, they don't have a partner that's willing to accept them? What would be a good alternative to colonoscopy?
Yeah, you're suggesting colonoscopy as the primary screening test, I imagine.
Yes.
Yeah.
Get them there because they can't afford it, and you don't have somebody that's willing to do it.
Right, absolutely. And a couple of things come to mind. First of all, patient navigation, as you mentioned. We actually have trained lay people from the community from East Harlem to be navigators and advocates of colonoscopy. And their only qualification to be a navigator was that they themselves had a colonoscopy. So many of them didn't even have college degrees or finish high school, but we train them to advocate and to explain to people, try to get them to overcome some of the barriers of fear, mistrust, or the yuck factor, or whatever it may be. Now, insurance, of course, is a barrier that patient navigators can't necessarily overcome. But in that regard, I think if you were to offer the patient a stool-based test, whether it's FIT or multi-target stool DNA, if that test is positive, you may have heard that recently there was approval, or there's a movement on the part of the government. Biden administration announced that if, as of this May, if a patient has a positive stool-based test, FIT or Cologuard, the insurances really must cover the colonoscopy as part of that screening episode. Now, right now, that applies to the Affordable Care Act. It's not yet ubiquitous. You'd have to see in your own environments whether that is being covered, but that may be a way of getting around this whole issue, meaning if a patient has no insurance, or they are underinsured, or they're whatever the issues are where they can't get a primary colonoscopy, at least have them do a stool test. And then if that's positive, just making sure that you have systems in place to really follow that up with a colonoscopy. Does that help?
It does. It helps a lot. We've still got a long way to go in dealing with the uninsured, the completely uninsured, because obviously that policy wouldn't apply to them. Dr. Hotz wants to know, is there a quality standard on how long after a positive stool test, how long do you have before the colonoscopy should be done?
Very good question. I didn't have time to touch on that. So probably the best data comes from Kaiser Permanente, because they have thousands of people that they've been following, and they have a formal FIT program there for their members. Their data shows that if you wait more than 9 months, or even more than 6 months after a positive FIT test before getting a colonoscopy, if you wait 6 to 9 months, certainly longer, the rates of advanced adenomas, the rates of early stage cancers, and the rates of late stage cancers all go up significantly, statistically significantly. So anybody who has a positive FIT test or a positive multi-target stool DNA, think of that person as if they had rectal bleeding. Like if somebody told you, I'm bleeding per rectum, you're going to get them in for a colonoscopy. You want to do the same thing for a positive FIT or a positive multi-target stool DNA. You're going to find lesions if you wait too long.
That's great. I remember your slide that showed the continuum, the progression continuum once it starts. it's a 2 to 5 year thing, but it's moving pretty quick across that first 2 years. Thank you very much. Kyle Kennedy, I believe, is from one of the East Georgia Healthcare Center sites, wants to know, let's see, what are your thoughts on patients who are Cologuard positive, but colonoscopy reveals normal mucosa? How often should we follow up with a surveillance colonoscopy, or I would guess also a follow-up stool-based test?
Yeah, very good question, a very popular question, and one that we don't have, perfect answers to. So let me frame that out. So if the Cologuard is positive and the patient has a colonoscopy and it's negative or normal, the first thing you have to ask yourself is, was that a good quality colonoscopy? There are metrics that we have for colonoscopy. Did the doctor get to the cecum? Was the bowel prep adequate? Was it good bowel prep? Was the withdrawal time more than 6 minutes? So if you have a good quality colonoscopy, I reassure the patient and I say, great news. Your Cologuard was positive, but the colonoscopy is really the gold standard, the deciding factor. You're fine. Now, before we had a lot of experience with multi-target stool DNA, there was a concern that if the colonoscopy was negative, maybe the DNA was coming from a cancer higher up in the stomach, in the pancreas, in the esophagus, in the lung even, because lung cancer, people, cough up sputum and swallow that DNA, that winds up in the stool. Studies have actually been done that in the Mayo Clinic, they actually did upper endoscopies, pancreatic CAT scans, chest x-rays, chest CT. They found nothing. In fact, their IRB put a halt to that study because it was thought to be unethical to keep doing all these studies on patients and finding nothing. There's other studies that have followed people after a positive Cologuard, negative colonoscopy in terms of their rates of getting lung cancer, esophageal cancer, et cetera, et cetera. Their rates are no higher than the general population. So one thing is for sure, if you have a negative colonoscopy, you do not have to work the patient up for an upper GI or an upper aerodigestive cancer. That you don't have to do, which is very reassuring. However, it's disturbing to have abnormal DNA in the stool with a normal colonoscopy. So the next question that comes up is, did the colonoscopy miss something? It's always possible. Colonoscopy is not perfect. Things hide behind folds. I usually tell people that I rely heavily on the colonoscopy. And my recommendation is to repeat the colonoscopy in 10 years. If people are nervous, you can do it sooner than 10 years. If you want to do a follow-up Cologuard in 3 years, you can do that. There's really no rule. The original label for Cologuard was, the first time test. The 3-year interval was more of a modeling, more of a guess. But people in the community are doing interval Cologuards or interval fit testing between colonoscopies. And maybe this is one situation where you might want to do that if you're nervous.
Sounds like a ripe opportunity for someone to do a more detailed study on what to do in that troubling interval. So
yes.
Well, Dr. Itzkowitz, thank you so much for that information and for sharing your responses to the questions. We do need to move on now. So with that, I'm going to ask, it's my pleasure to actually introduce Cynthia George, who's the CEO of Horizons Community Solutions, and Dr. Robby Amin, who works with her there. And they're going to present today's case study highlighting patient navigation. Again, we'll try and keep this to about 10 minutes and hopefully leave some time on the back end for additional questions or comments. So with that, Cynthia, please take over. Thank you.
Thank you, Dr. Patton. I'm going to really briefly just skip over the history of who we are and where we were founded and all of those things to get to the real meat of what we want to talk about today. We are one of Georgia's 5 cancer coalitions, and we are the one for South Georgia, and we have been a partner with Georgia Core since long before my time here. And as well, Dr. Itzkowitz, we owe that gratitude and honor Dr. Hotz for all of the work he's done in our community and in getting this organization started and our whole screening program started. So thank you, Dr. Hotz. I'm going to hold with that and turn it over to Dr. Amin to talk with you about our process of workflow here with our community screening program. Dr. Amin.
Thank you so much, Cynthia. Next slide, please, someone. So before I walk through the workflow process, I think it's important to describe the term patient navigator. Although it may seem straightforward, I know many of you participating in this echo can attest it's a role that has taken on several different definitions and expectations, and it varies between clinics and health systems. At Horizon, from the moment the referral is received from a provider, a navigator guides a patient through the entire screening process, hand in hand, one-on-one, while addressing barriers to care, patient concerns and fears, providing individual coaching and education, and arranging for any and all appointments necessary until the result is obtained in a patient's file. The slide here shows the workflow process involved. There's generally 2 phases in the navigation process. And on this slide, you see the workflow for phase 1, which is enrollment and scheduling. The process begins with the clinician assessing the patient and referring them for screening. If a patient agrees, then this referral is sent to a Horizons navigator and they contact and interview the patient. As you can see in the slide, this is the process for a colonoscopy with us in AAPHC, and you can follow the process along to see how they handle any and all scheduling, paperwork, and bowel prep instruction necessary. However, if a patient deems the patient of average, or the provider deems a patient of average risk, and they choose a FIT or fecal-based test instead, then after the interview step, this over there, the process proceeds to phase 2. So Selma, next slide, please. Phase 2 is patient reminders and coaching. This is where a lot of difference is made, really. The reminders and coaching are the hand-holding part of the equation. And that makes the patients more likely to return their FIT tests or show up to the colonoscopy appointments on time and with good prep. These process maps show the workflow, but I can't stress enough the human aspect of this navigation process, particularly when dealing with patients with many barriers to care. That's what really sets the Horizons program apart. And before I throw it back to Cynthia, because I know we're short on time, I wanted to highlight an example of a life that possibly saved by our partnership and our program. So in December of 2019, a patient at one of our AAPHC clinics at Dawson Medical Center was referred to Horizons for a FIT test. He was successfully navigated and received a positive result. So he was immediately navigated for a colonoscopy following that result. And when the pandemic, everything came around, everything was put on hold and the GIs couldn't schedule him. And so he couldn't get his colonoscopy. Unfortunately, during this time, he also lost his job and insurance coverage. When he returned to Dawson Medical Center in 2021 as an uninsured patient, his physician there at AAPHC sent a referral for an uninsured colonoscopy to Horizons. The navigator was able to get him scheduled right away with Phoebe GI, and he was found to have a stage 3 colon cancer. And so with this result, the patient had to be taken to surgical oncology, which the navigators at Horizon were able to help schedule and get him the treatment he needed in a timely manner. Now, without a program like ours, a patient like this would have fallen through the cracks and been unable to get the appropriate treatment and care that they deserve. And that's just one example of many that this program has helped over the years. But none of it could have been done without the strategic partnerships that we have in place. And to that, I'll go back to you, Cynthia, to finish up.
Thank you, Robby. This is probably the most important part of our discussion with you is talking about partnerships, because as we all know, it's fine to get the FIT done, the FIT returned, but when you have somebody that needs a colonoscopy, or worse yet, someone that has a positive colonoscopy and needs treatment, you have got to have the partnerships in place to make sure that that patient is taken care of. We feel like that is our commitment. I mean, we have to have that before it has to happen. We have to know that we have those relationships. So partnerships are really the most important part of the work that we do, and it's key to sustainability of any successful colon cancer screening program. A health system that values and understands the need to catch cancer early and provide such a life-saving benefit is key and vital as a partner in this work. Our navigators are part of a team at each clinic. They partner with and strive to lessen the burden and improve the process. We work hand in hand. Horizons navigators work closely with physicians and hospital partners to educate and guide the patient through the entire process. It is indeed a partnership, and it's the key to overcoming one of the hardest barriers for our patients. I want to share with you in closing just a study that was done by the Emory Prevention and Research Center about our community cancer screening program that was developed more than a decade ago. They wanted to find out if our program really made a difference and if it worked. And we wanted them to too, because we were seeing great results, but we wanted to see why we were getting those results from this program. So they interviewed 9 clinics, I believe was the total, but they found that 25% of people in the Southwest Georgia area live below the federal poverty line. And we have a higher colorectal cancer occurrence and death rate than the state of Georgia as a whole. So that was their key reason for coming to Southwest Georgia to look into this program that was seemingly increasing colon cancer screening rates. Next slide, please. And they wanted to answer, what they wanted to answer is, can a patient navigation program increase screening among under and uninsured patients in Southwest Georgia? And I think that's an underlying question here. And they studied 13 FQHC clinics in rural areas. 4 were navigated by Horizons and 9 were not. Over 800 of their charts were reviewed over an 18-month period, and the results were in. Next slide, please. Working with healthcare systems and providers, which many are on this call today, to address structural barriers to screening, like assisting with transportation to screening, coordinating screening for our patients, and following up with services and providing one-on-one patient education and appointment reminders. Next slide. It works. Patients who were navigated with the CCSP intervention were 5 times more likely to receive a colonoscopy referral, 8 times more likely to have a colonoscopy, and 6 times more likely to be guideline compliant. And this evaluation was completed before Horizons became a Fit First program. When engaged and motivated teams partner with Horizons screening program, and this program sponsored by and funded by the CDC, patients, practices, physicians, and care teams will all benefit and save lives. It's recommended in the CDC's community guide, our screening program is, as an evidence-based strategy for colorectal cancer screening, and was published in Cancer. We are excited to include all 4 of the evidence-based initiatives that the CDC recommends through our navigation program, so that we can make sure that we raise our partners, our patients, our clinics, our physicians. All of our screening rates in Georgia is a part of our program. That concludes our presentation. Dr. Patton, we're happy to answer questions.
Thank you so much, Cynthia and Robby, for the presentation and for the great story. Robby, unfortunate story, but a great story nonetheless that illustrates what happens when there are delays and challenges. We've got maybe just time for 1 or maybe 2 questions that we can get in the chat, or if someone has a comment to raise their hand.
I see Dr. Hotz's question. I'll just answer that right away. The question is, how much does navigation of FITS increase the return rate? So that's something that we're extremely proud of here at AAPHC and with the Horizons partnership, is that we found that in one of our clinics particularly, and actually across the board is pretty close to that, is that for those that are navigated, we had last year alone, 2021, we had an 80% return rate, which is huge. That means that the ones that are coming to us, are coming to the patient navigators, 80% of those are actually coming back, as opposed to how many would fall through the cracks had they not been navigated properly.
That's terrific. So there's a question for you, Cynthia. Is the increase in colonoscopy referrals a result of positive fits, or what is the mechanism for that?
No, as a matter of fact, this study was done really before we became a Fit First organization. So it is all colonoscopy screening.
Perfect. All right. So the question of the day then basically is, does navigation help increase colonoscopy or colon cancer screening rates in the uninsured and underinsured? I feel very positive about the presentations that you've heard today from a baseline perspective from Dr. Itzkowitz and from Horizons that really address that question. We're kind of getting close on time here, but certainly if you have thoughts about that, we'd welcome to see those in the chat about your own personal experience with that. And certainly if you have experiences that you would like to share in the future, this will be a good time for you to start thinking of that. But with that, I'm going to turn it over to Dr. Koosh Desai, who's going to talk you through the process of getting CME credit and then close us out. Koosh?
Yep, so the CME, I just got an email. This CME is going to be active tomorrow. And so we'll send out an email to everybody, all the participants, to get their CME that wants it. And so we'll be sending out an email with that. We're also going to be sending out an email with feedback. We want these sessions to be robust and informational for our clinic providers. And so we're going to be sending out. So please fill out that feedback form so we can help these sessions be beneficial to you guys. Lastly, want to give a big thanks. First, let's thank our partners at Georgia Core, Cheryl Gabram and Lynn Durham, who's the president of Georgia Core, and Cheryl is the PI of the grant, for hosting the grant and also for supporting this Project ECHO curriculum. Thank you to Dr. Patton for facilitating. Thank you for Dr. Itzkowitz for participating as our content expert, and to Robby and Cynthia for your presentations